So my name's Gemma Eminowicz. So I'm a consultant clinical oncologist and the brachy lead at UCLH in London. And I am also gynae specialist advisor for GenesisCare and have been working on this MR Linac boost protocol for gynaecological cancer. So I'm just going to run through a bit of background and then we'll talk through what we are doing within GC. So we know that within the UK, there's a significant number of new cervical cancer cases, despite the fact that we have had screening implemented for a long time, as well as the HPV vaccine. And there are a significant amount of deaths as well. And for stages 1B3 to 4A, so that's a large proportion of patients. So any patient who has a tumour larger than 4 centimetres, and it can be up to invading the bladder or the rectum, the standard of care is chemoradiotherapy, and that involves 45 gray and 25 fractions over 5 weeks of external beam radiotherapy, where you're treating the pelvis to treat the nodes, as well as the primary, the uterus, the upper vagina, the parametra, and essentially cervical brachytherapy. And this allows us to achieve doses that are equivalent dose in 2 gray per fraction of 85 to 95 gray to the high-risk CTV D90 prescription. And the high-risk CTV is your target area. So it's where the tumour is, it's the cervix, the residual tumour, and the grey zones at the time of brachytherapy. So you can see the brachytherapy delivers a significant proportion of the dose of radiation that cures these patients. Here you can see some examples of the type of external beam radiotherapy we deliver, where you're using intensity modulated radiotherapy to boost nodes as well as treat the pelvic nodes and the paraortic nodes and the entire uterus, the cervix, the upper vagina. And then here you can see the flexotron, which is a brachytherapy machine, so that's where the radiation is, and this links, the source then comes out of this and goes into these applicators. So these are examples of brachytherapy applicators. And with modern day image guided adaptive brachytherapy, we're able to really conform shapes. So historically, brachytherapy would deliver just a pear-shaped distribution, and now we can use needles to really shape that according to exactly where we want to treat, and minimizing the dose to the organs at risk as much as possible. And really this image guided adaptive brachytherapy has been driven forward by the GenesisCare and Embrace group, and excitingly this weekend at ESTRO, the Embrace 2 first outcomes are being presented, which is looking at all of this, so intensity modulated radiotherapy, image guided radiotherapy, as well as image guided adaptive radiotherapy, brachytherapy within locally advanced cervical cancer. And importantly, there's things on here which have been highlighted within the Embrace data, showing that outcomes correlate with making sure that you have a low overall treatment time. So you should receive your treatment within 50 days, and also about risk categorizing patients. So making sure that you're treating the right lymph node areas, etc. Here we've got quite well established now organ at risk dose limits, which have come out of the Embrace trial data. And we've got your optimal and mandatory constraints, which we tend to focus on the D2 cc's, so the dose received 2 cc's for your bladder, rectum, sigmoid. However, having said about how important brachytherapy is, there are limitations to brachytherapy. So sometimes there are tumour factors, so poor treatment responses, very irregular large volumes, or severe fibrosis that mean that you are unable, even with needles, to get good coverage, or even whether the fibrosis stops you from actually being able to put the applicator in. There are patient factors such as unfavourable anatomy, because obviously we have to access everything vaginally, and then there's comorbidities. This, I think, is becoming less of an issue because with anaesthetic risk, we're able to do spinals, and a lot of patients can have prehabilitation, etc., to ensure that they are fit for anaesthetic. But bleeding risk is still significant. And there are situations, for example, previous psychological issues or events that may cause patients to decline this sort of treatment due to the invasiveness. There are technical factors such as procedural challenges, such as perforation or bleeding, that may mean you cannot deliver the treatment. In some countries, there are resource or logistic issues, though thankfully that's not significant within the UK. And there are also interfraction anatomical changes, and there can be dose deviation due to catheter positions, which can affect treatment delivery. And informally, we just asked some UK clinicians whether they ever have occasions where they cannot do brachytherapy. And out of 10 clinicians who responded, the average was actually that about 1 patient a year was unable to have brachytherapy. And often the doses that are given as an alternative are quite low, only achieving EQD2 doses of 65 to 70 Gray. In centres which have experience with SABR, they may deliver SABR to try and achieve doses higher than that, because this is recognised to be not enough to cure these patients. Now, as an alternative to brachytherapy, there have been studies looking into this, and as I said, there are occasions where it cannot be delivered, and data has been collected on these patients. An external beam radiotherapy boost is used if brachytherapy is not possible. Historically, that is a lower dose prescribed than with brachytherapy, and also there's the issue that you need a margin. So with brachytherapy, because the applicator is inside your target area, you don't need a margin between your clinical target volume and your planning target volume, but for external beam radiotherapy you do. And also the intense dose hotspots are absent, because with brachytherapy you get very high doses centrally, which are not replicable with external beam radiotherapy. The use of intensity modulated radiotherapy can increase organ at risk sparing compared to conformal, and it therefore has allowed people to deliver boost doses up to 30 Gray, and that is feasible within comparable organ at risk doses. However, what is clear is that from all the data that has been published to date, bearing in mind that obviously survival data needs long follow-up, there is a significant survival advantage to receiving brachytherapy as your boost compared to external beam radiotherapy. You can see that on these Kaplan-Meier curves here, and you can see 42% reduction in cancer-specific mortality in patients who receive brachytherapy compared to external beam radiotherapy. 5-year cancer-specific survivals of almost double if patients receive brachytherapy. And a SEER database review corroborated this as well. So brachytherapy is really important in these patients. And the question is, why is that so much different? And as I said, this data obviously needs long-term follow-up. So therefore, maybe the newer technologies of radiotherapy can allow us to perhaps narrow that difference. Whether it would achieve brachytherapy outcomes, that is questionable, but certainly we could narrow that difference that there's there. So SBRT can deliver similar doses, so you can replicate the prescriptions that you're prescribing with brachytherapy, so for example 28 Gray and 4 fractions, and there are small studies where there has been patients treated in that way with reasonable 2-year cancer-specific survival. There was a phase 2 trial looking into stereotactic radiotherapy to replicate brachytherapy doses, but actually it closed early due to significant toxicity. So more than a quarter of the patients had grade 3 or more toxicity at 2 years. But in this trial, most of the tumours were above 100 cc's, and that may be contributing to that. So stereotactic MR-guided radiation therapy can allow equivalent EQD2 doses to be delivered via prescription with organ at risk sparing. However, this demonstration is quite a crude image on A, but what you can see is A is brachytherapy and B is an external beam SABR boost. So you've got your 100% dose, which is your red. But what you don't have on your B is your 200% dose. So this blue is 200% of your dose, and we don't achieve that with the external beam. So the question really is whether perhaps that's what makes a big difference. So what could be the role of the MR Linac in this situation? So the MR Linac, because it uses MR guidance, so you can replan daily, and you can also do tracking at the time of delivering your treatment. It gives you superior soft tissue imaging compared to cone beam CT. There's no question about that. It allows online adaptive replanning, so you can adapt to any positional changes according to pelvic motion on a daily basis. You can tissue track and automatic beam gate, meaning that if at that time when you're delivering the treatment, there is a change with bowel or rectal gas, then actually the beam will switch off and will not deliver the radiation if the target is not in. There's no need for fiducials, unlike some other technologies like CyberKnife. You can therefore use smaller PTV margins. You still need a PTV margin compared to brachytherapy, but it can be smaller, so 3 millimeters compared to 5. And with that confidence of all of these things, you can potentially dose escalate internally a bit more. It's non-invasive, there's no need for any anaesthetic, there's no inpatient stay, there's no limitations due to the target shape, and there's no procedural risks, which obviously these are things that come with brachytherapy. So there are important considerations on set. So coordinations of appointments with external beam radiotherapy is really, really important because we've already mentioned that overall treatment time correlates with outcomes. So we know that extended overall treatment time is equivalent to losing radiation dose essentially. And so it's important to coordinate that appropriately. Ideally, if you're delivering this as a boost for a patient who cannot have brachytherapy, then the MR sim should be in the 5th week of conventional treatment. You don't want to do it too early because you will get significant shrinkage of tumour, but obviously you need time to do adequate planning. However, in most people's experience, you cannot predict when a patient cannot have brachytherapy. So it's likely that referrals will come through in the 6th week. And it's potential that you could consider using a week 5 MRI to help plan this, but obviously the quality of that needs to be good. Vac bags could be required, but there's height restrictions with the couch, so this is something that we probably won't be doing. And importantly, patients are going to start with side effects. So patients have already had external beam radiotherapy and will start this treatment with side effects. And we're going to be expecting them to fill their bladder, similar to prostate protocols, and potentially prepare their bowel with microenemas. And in that situation, these patients have to lie on a couch for up to an hour, and it's important to consider how they're going to be able to do that. There's no need for any contrast or any Buscopan, but I think it's very important, and what we've worked on at GenesisCare and what we need to make sure we're happy with before we go live with this sort of protocol is that we have a fast track pathway because of the importance of the overall treatment time. So looking at actual evidence specifically for MR Linac in Gynae Boost, there are dosimetric studies which show that MR-guided radiotherapy that is feasible. So this is a feasibility study of 10 patients with only 2 of them actually being locally advanced, but 8 of them were recurrent cancers that were receiving external beam radiotherapy followed by a brachytherapy boost. And they were not able to receive the brachytherapy, so they were able to receive 73.6 gray median dose within acceptable organ at risk tolerances. And none of these patients experienced any grade 3 toxicity. However, treatment delivery was a median of 77 minutes. There is also a currently recruiting trial, which is recruiting in the UK at the Marsden in Sutton, and this is the Margarita trial. So this is a MRL consortium observational trial in Unity centres, which is looking at MR Linac boost for gynaecological cancers if brachytherapy is not feasible. So exactly this scenario. They deliver 6 fractions over 2 weeks, and there's been some early data showing feasibility and complete responses in patients with smaller tumours. And this is ongoing with recruitment, and hopefully we'll continue to provide more information in this arena. So we have done some planning test cases at GenesisCare, and later Ebison will go through a little bit of examples. And essentially we wanted to assess if we could achieve a radical dose to the high-risk CTV in the region of 85 gray using the MR Linac, whilst maintaining SABRE planning and organ at risk constraints. Obviously we assumed that patients had received 45 gray and 25 fractions with no recovery, because you would assume that this is given immediately after external beam radiotherapy. And we initially planned, so this work was actually started previously by Vicky McFarlane, and they originally looked at the SABRE consortium guidelines for reirradiation for organ at risk tolerances, and then we've also looked at the EMBRACE organ at risk tolerances as well, seeing as that is established and there's lots of very good data on that now. We've used 8 MRI data sets where we outlined the target and the organs at risk with a margin CTV to PTV of 3 millimeters. We planned to deliver 30 gray and 5 fractions to the PTV with a boost simultaneously to the CTV of 35 gray. And we aim, so we use the PTV and CTV coverage, but we also do the PTV high. So this is essentially the PTV without the areas of overlap with organs at risk. And this is the area that we're really trying to achieve the embrace coverage dose, the D90. The CTVs that we had in these 8 cases was a median of 36 cc's, but up to 122, so quite a good range. And here you can see that actually the doses that we can achieve are good. And we've pushed the doses for the Dmax to about 175% of prescription, so that we're able to try and peak the dose internally. Not as high as with brachytherapy, but we have the confidence using the MR Linac to be able to boost that dose. And you've got your PTV high, D90 median dose of 87.5 gray, which is really good. Interestingly, with the organs at risk, really it was the rectum that was the organ at risk that we were having to plan against as such. So this was the limiting organ at risk. And we kind of opted to try and see what we could achieve within 70 gray, because the mandatory dose is D2 cc's up to 75 gray, but we thought it'd be good to have a bit of scope, because obviously when you're delivering treatment on a daily basis, then potentially the dose will vary on a daily basis, even though you're optimizing. And so you need to give a little bit of wiggle room as such. But you can see bowel doses in general are quite good, and the bladder doses are also good. So we're proposing to launch a protocol next month, which will essentially be exactly that planning, as those planning cases were done. So we will prescribe 30 gray in 5 fractions to the PTV, with a simultaneous integrated boost of 35 gray to the CTV. It's 5 fractions, alternate days, so over 10 days. The PTV will be the high-risk CTV, so we outline as per brachy guidance, plus 3 millimeters. We'll treat patients with a bladder full, and initially with a microenema for rectum empty, but we'll see how that goes, whether that is necessary. And the doses we've already explained would be what we're aiming for. Importantly, what we've worked on is trying to make sure we have this fast track access. So patients, if there is a reason that a patient is known to not be able to receive brachytherapy, then we can get a referral early, we can do the planning at an appropriate time, and actually the patients would receive treatments within 55 days, which is a relatively good overall treatment time. We like to keep within 56. If the patient has a failed brachytherapy the week after their external beam and gets referred at that point, then the overall treatment time obviously will be a bit longer, but we can try and expedite things as much as possible as they go through. So in conclusion, the MR Linac could allow dose escalation compared to standard of care external beam boost in patients unable to receive brachytherapy. This has a significant potential to improve outcomes in these patients, and a similar protocol obviously can be applied to other gynecological tumours requiring external beam boosts. And hopefully at some point in the future we'll be able to present some data regarding patients that we have hopefully treated. These are the references, and thank you very much for listening.
My name is Ebison Chenherende. I'm a medical dosimetrist. I'm based in London. I work for GenesisCare Cromwell. I solely specialize on planning the dosimetry on the adaptive MRL platform. So we're going to talk about the physics and dosimetry aspects of the MR-guided adaptive radiotherapy. And to begin with, I'm going to go with a case that was referred to us in 2021. This case, it was referred as a re-irradiation case to us. Of course, as when we looked at this case, it's a gynae case. They did a phase 1 treatment of 61 gray in 33 fractions, and then they attempted brachy. The patient actually turned up for brachy, and they failed to deliver brachy. They then tried to, they ended up delivering a 16 gray in 8 fractions boost. And one of the things that they noted there were some challenges of poor images of the CVCT. And when we analyzed this case, well, the treatments that were done, the radiotherapy treatment that were done, forget about the recurrence that happened in 2021, you would see that the EQD2 as the total EQD2 combining the 61 gray in 33 fraction and the 16 gray in 8 fraction it's quite low, only 76.23 gray. And as the IMPRESS protocol, you would see what we're expecting there is somewhere above 8.5, but this was too low, and it's not surprising that this patient actually recurred. The EQD2, we are talking of equivalent dose to gray, and this with this analysis, we can tell the difference between different dose fractionation, different dose prescriptions that we use in radiotherapy. And the other interesting thing as well, with the 6.1 gray in 33 fraction and the boost of 16 gray in 8 fractions, you definitely use a max dose of 107. That's your global max. Some centers, of course, they would go 110. So we did not have enough hotspots in there that brachy would do. And so it's quite not surprising that there was a recurrence there. And if you were to look at in literature, to look at what other dose fractionations that were used for external beam in cases where brachy was not possible, there is a variety of them, and they use different platforms, ranging from some they've used 2 fractions, 14 gray in 2, 15 in 2, 20 in 5. There's some as well that have used almost 13.5. But the most interesting platform where they try to use external beam radiotherapy is when they use the CyberKnife. But as you can see, with CyberKnife, the fiducial markers are required. And also the PTV margin is a bit big compared to what we offer with the MR guided Linac, so 5 millimeter. So when you look at the literature where brachy failed and then they resorted to external beam radiotherapy with a 5 millimeter margin, you're introducing some damage to the normal tissue, that which we don't do on MR Linac. So the literature that's there, of course, there's some they've reported no toxicity, but there's been some issues of fistula, perforation, bleeding, and all would definitely be linked to the 5 millimeter PTV margin that was used. And obviously, they were not really using the adaptive, the fiducial markers compared to the MR Linac. It doesn't match. Sorry. So we go to why is brachytherapy the treatment of choice as a boost. Brachytherapy capitalizes on the inverse square law, so the dose is dumped more into the tumor, and there's minimum dose to the normal tissue, the surrounding tissues, and that's the trump card for brachy, and it's difficult to reproduce that anyway with an external beam, but there are some weaknesses of that. And the toxicity when it comes to the intracavitary brachy, some publications, they've reported toxicity of about 1.7%, but the interstitial, the toxicity goes up to 13. And as we can see, when we talk of brachy, the dose to point A, and point A, that's 2 centimeters up to the cervical os, and 2 centimeters lateral to the midline to the tandem catheter. It goes to, there is a range for gray in 4 fractions of 7 gray, 5 fractions of 6, 6 fractions of 5, and also 5.5 fractions of 5.5 gray or 5 fractions. It goes up to some international centers. They use they deliver 9 gray in 2 fractions, and some they have reports of 8 gray in 3 fractions. And this is the catch. This is the trump card for brachy. But however, there is a downside of brachy. There is risk of perforation, and it goes up to 14-15%. And when perforation happens, the dosimetric impact is huge. As you can see on this image, you can see that's the target, that's the CTV there. And because of the perforation that has happened, the DOS is actually missing part of the PTV. And it's not surprising that there have been cases, including one that Dr. Meyer demonstrated, where there's been recurrence after brachy and external beam. And again, this as well, you can see almost we are missing the target there, and the perforation. We're actually overdosing the organ at risk, which is the bowel or the sigmoid colony there. The other issue with brachy, there's an issue of needle migration and also the anatomical variation, like the gas bubble can just develop these peristaltic movements, there's inflammation, there's edema, there's also MSS, etc. The patient can cough. That cannot be encountered, catered for when it comes to brachy. And the University of Michigan, I think 2019, they compared the planned dose and the delivered dose for brachy. And as you can see, they sometimes, of course, we've got more dose below the 0, but there's a displacement going up and a maximum of more than 5 gray, more dose to the organs at risk, the rectum, the bladder, the sigmoid, and the bowel there. So this is the downside of brachy. And also there's an issue of deviations. The catheters can deviate up to 4 millimeters, has been reported in literature. So when we look at MR guided, the most attractive thing about the MR guided Linac is 3 millimeter PTV margin. That's what we use. That's our standard. Also, this precise soft tissue visualization, and when because of the soft tissue visualization, we adapt each and every fraction, and we can image the anatomy of the day on adapting each and every fraction, and it becomes easy for the onset team, the onset consultant on when we're doing the online planning to outline the target, outline the organs at risk nearby, and also we have automatic beam getting. We have got the real-time interfraction tumor, and nearby we can actually track the tumor, we can track the organs at risk nearby, and we do that in 3 planes. So it becomes easy for us because we have got the help of the machine intelligently to switch on or switch off the beam, depending on the anatomy. We can re-optimize on set, such that we can actually capitalize if the anatomy is favorable on the day. We can capitalize, improve our coverage. If the anatomy is not favorable, we push down and save the organs at risk to go isotoxic. That basically allows us to escalate the dose because we can visualize our hotspots, where our hotspots is on each and every fraction when we are adapting. And the fact that with A3i, there is auto-contouring, auto-adapt, auto-get, that streamlines the process, and when we are adapting, it takes not much time. I think the patient can walk into the Vanguard and walk out in 25 to 40 minutes. And this graph is just showing the advantage of adaptive radiotherapy on an MR Linac. The coverage, if the anatomy, if we are to apply the baseline plan onto the anatomy of the day, you can see that's the predicted plan there. You can see the coverage drops. And also the organs at risk. The organs at risk will receive too much dose there, but when we re-optimize on set, we can tweak the objectives, the dose constraints, and the cost functions. And that way we can actually improve the coverage, and we can significantly improve the coverage, the PTV high, which is part of the PTV not overlapping with the organs at risk. We can save the organs at risk, and you can see there is a big difference. You're pushing it down to be in tow, and you're pushing it down to be in tow, and we can go isotoxic, or we can use the ALARA principle as well there, and that's the optimization that we do on set. And so the 25 to 40 minutes, that includes the optimization, the quality checks, the recontouring that we do. So our prescription dose for our protocol is going to be 13.5. And the biggest advantage with our prescription is we are boosting the CTV to 35 gray, and that gives an equity of 49.58 gray. And we are allowing hotspots up to 52.5 gray, and that's of up to 1 cc in volume. And that alone, it gives us like 150% of the boost dose and 175% of the PTV prescription dose. I think as Dr. Gemma explained, our target aim is to cover the PTV high with a cumulative equity dose of 885 gray and cumulative equity dose to PTV of 80 gray. And for the CTV, we are aiming for equity to dose of 90 gray. And no chemotherapy will be delivered concurrently during adaptive MRL SEBA. So this is our Planner X. And the aim of this Planner X, of course, is to make sure we achieve the IMPRESS equity to dose limits. But also we included the 0.1 cc to make sure we can nudge off the hotspots away from the organs at risk, which is the bladder, the rectum, the bowel, and the sacral plexus. For the femoral head, we will be applying the dose constraints, and this will be calculated as per a AMPM TG101, considering the phase 1 dose as 45 gray in 25 fractions, and sometimes can be boosted to 50.4. But when we are doing these calculations, there will be zero recovery applied when we do our RBE calculations, and we will be using an alpha beta ratio of 5 for bladder, 5 for rectum, 4 for bowel, and 3 for the femoral head, and 2 for the sacral plexus. This slide is to show a typical plan, an example of the plan that we're going to be doing for our patients that's going to be referred to us. And with this plan, one thing that's outstanding, you can see the 45 gray, which is the bold and right in there, and the 45 gray, it gives you an equity to straight out of 71.2 gray. This is really good. And also we can look at the 50% isodose. It's quite conformal, it's controlled. And this coverage that you see of the total cumulative equity to dose for the CTV is very good, despite the fact that this case, the bladder was not too full. So the MRL is a great platform for boosting these. And of course, this we're talking of cases where brachy fails, and then we're going to do an MR-guided SEBA. But we have got quite a number of cases that's been referred to us where they've done the 45 gray in 25 fractions, and then they boosted, they did the brachy, and then those patients recur, they come to us. And I think with Dr. Meyer case, we had to do it twice. We went in, we delivered a 13.5. We had to go back again in and do 13.5. Of course, a slightly different location, but very close. So that alone, it just shows you how great MRL is. Of course, there are some limitations with the MRL-guided SEBA. Some patients are claustrophobic, and of course, sometimes we have to do medical intervention there. And also some patients may struggle to lay still on the couch for 25 to 40 minutes. And obviously, if a patient has got some ferrous metallic foreign bodies, it's an issue. We cannot do that. We cannot treat them on an MR Linac. And the other issue, obviously, if the lesions are too small, they may be difficult to track. But for Gynae, obviously, we are tracking the whole, we can track the whole uterus, or sometimes we can use the surrogate, or we can track the hysterectomy calf as well. So to conclude, I would say for patients that are unable to have brachytherapy procedure, an adaptive MR-guided SEBA boost offers a safe, and when we say safe, there is evidence that we can actually serve the normal tissue, and we can escalate the dose. We can review where our hotspots are with absolute certainty when the patient is on the bed and we are actually treating the patient, and we can escalate the dose to achieve a higher BED and our standard dose will be 13.5, boosting the CTV to 35 gray. So these are my reference, and if anyone has got any questions.
Thank you, Ebison. That was really comprehensive. We appreciate it. We haven't had any questions posted into the meeting chat, but let me just open up the actual microphone so people can ask questions right away. So let me go to this. Okay. So microphones and cameras should work. So if anybody would like to ask any questions, please do raise your hand and we'll go ahead. Vicky McFarlane has got a hand raised. Yeah, please do ask away, Vicky.
Hi, hello, that was really interesting. Thank you to all the speakers. I suppose my question really is whether Genesis will offer this treatment strictly to self-pay or private patients, or whether there may be an option for treating patients that don't have funding for the brachytherapy boost, because I think that's the large majority of our patient population with cervix cancer, and certainly my experience of the ones who could possibly benefit, which I think they would, from this treatment. So that's my kind of first question.
Thanks, Vicky, and thanks, Vicky, for the work that you put into this as well. But yes, so GenesisCare have agreed to an innovative pathway, patient pathway, which essentially will allow UK residents, non-insured patients, to be able to access this treatment. We are hoping to go live next month, and any patients which do have problems with their brachytherapy, they have no access, or whatever happens at the time of brachytherapy, I'm very happy to be contacted to see how we can assist with that. Obviously, we'll be tracking the data and seeing, and it's not an indefinite thing, but these are not big numbers of patients, these are very small numbers of patients. So that is something that will be accessible for UK residents who are not insured.
Thank you.
Good question, Vicky. Pauline, you have a question as well.
Just following on from that, Vicky, does that, Gemma, mean that there will be some specific centres, GenesisCare centres, that will offer it, or will that potentially be all GenesisCare? I'm aware that we have that the centre in Bristol, but not sure if they will have the expertise to do what you're doing.
Yep, so good question. So it's where the MR Linacs are. So at the moment, that is the Cromwell, Oxford, and hopefully soon to be Guildford. So it will be in the MR Linac centres only. Yeah, but obviously, we can. I mean, for the patients, it will be better than a standard external beam boost with the sorts of doses we can deliver. So it's just a matter of seeing where is closest of those locations for the patients.
Lovely, thank you.
Does anybody else have any questions? Don't want anybody to go away and feel like Mark's got a question. Go for it, Mark.
Hi everyone, thank you for the amazing talk this evening. It's great to see that there's an option to do a boost after 45 and 25, but are there any feasibility studies where an SIB process could be done on the MRL for the full duration of treatment?
So good question. At the moment, there isn't. I mean, I think it's something which, I mean, I guess, brachytherapy is should be the gold standard for these patients, which obviously, you know, it's kind of knowing that a patient is not suitable for brachytherapy at the beginning is often quite a rare thing. I think, you know, it's certainly a good question, a good thing to look into. You know, there's potential with the MR Linac of having a lot more kind of confidence in doing your SIB during your external beam. The sorts of doses that you'd have to be delivering on a daily basis, it's sort of, yeah, I mean, you'd need to think to achieve your 85 to 95 Gray. But it's certainly a good question, and something we can potentially look into.
Lovely, thank you.
Thanks, Mark. Has anybody else got any questions? I don't want anybody to go away thinking, I wish I'd have asked that. So please do ask away.
I'm very happy to be contacted after this. Yeah, we can put our contact details in the chat.
Yeah, that's a good idea.
I'm the only Eminowicz on NHSNet for anyone who is on NHSNet, so it's very easy if you can spell it.
Okay. Right. Yeah. Please make a note of Gemma's email, everybody. If you'd like to find out more about the MRL boost for Gynae. If there are no more questions, then I think we'll close the webinar here. I'd just like to say, you know, thank you everybody for attending. Huge thank you to Gemma, Maya, and Ebison for their presentations and all the work they've done in the background. We really appreciate them. And yeah, and like Gemma says, if there are any questions following the webinar, please do contact us, and we will get back in touch with you straight away. Thank you. Okay. I'll end the event now. Okay, this is gonna appear quite abrupt for everybody.
Thank you.
Thank you.
Yes.
Thank you.